So hello all and welcome back to the channel Transfusion Squared. And in today's episode, we will be discussing about therapeutic plasma exchange. So the device which we have at our place is Spectra Optia. So we'll be taking you through how to load the kit for a plasma exchange on this instrument and what are the precautions to be taken, the requirements before we start a plasma exchange and a common FAQs which is faced during the procedures. If you have any other queries or you want to know further in depth about the procedure, you can always comment in the comment section. So to take you through the entire procedure, we have Dr. Ankita with us, who is a registrar at Indraprastha Apollo Hospital. So she'll be showing you how to install the kit and how to start the procedure and end the procedure properly. So over to you, Dr. Ankita. Thank you.
Hello friends. Today we'll see and discuss how to perform therapeutic plasma exchange using the Spectra Optia apheresis system. So the Spectra Optia system is based on the principle of continuous centrifugation and optical detection technique, which is also known as the automated interface management system. This system continuously monitors and adjusts itself to optimize the separation procedure of the blood and allowing the efficient collection or removal of the desired component. The therapeutic plasma exchange procedure is performed in variety of cases such as renal transplant cases, liver transplant cases, in neurological cases, cases of poisoning, etc. So today we'll be performing therapeutic plasma exchange on a patient who is awaiting a renal transplant. So this is a 45-year-old male patient, known case of chronic kidney disease, planned for a ABO incompatible renal transplant. Patient is of O positive group and the donor is A positive. And we'll be performing a plasma exchange for the purpose of desensitization. 1.5 volume exchange will be done with 80% replacement using saline albumin, and towards the end 2 units of fresh frozen plasma AB group will be given. And before we are going to bedside to perform the procedure, we'll go through our checklist. That is, we have received a duly filled request form. There are written orders for plex mentioned in the patient's file. We have obtained a written consent from the patient. We have checked for the consumables, that's saline, albumin, and etc. We have also checked with the patient's reports, that's blood group report, the viral marker report, a complete blood count report. The access in this case is a AV fistula. And lastly, the machine with the appropriate filler and the designated kit is ready to start the procedure. So we'll now select the procedure which we need to perform on the Optia. We click on the icon and see list of procedures such as therapeutic plasma exchange, mononuclear collection, continuous mononuclear collection, red cell exchange. We'll select the TPE protocol. Once selected, press confirm. Now the corresponding software is getting loaded in the system. So we'll now check for the requirement of TPE, that is the filler and the exchange set. The filler is the standard filler. Next, we should check for the exchange set, which is orange colored. The reference code is 10220. We'll check for the expiry date and the lot number. Once checked, we'll move on to the next step. So now we'll check for the filler, which is the standard filler. The other filler is the ideal filler. So now after checking the standard filler and the kit, we'll press continue. The next step is to prepare the tubing set. We press on that and we can see the steps which is shown. First is to remove the cells and the bags. The second step is to snap in the cassette and hang the bags. Third is inserting the channel, and fourth is to close the door. Now we'll unbox our kit. We'll check for the reference code and the expiry and carefully open the kit cover. Once open, we'll check the tubing sets for any visible occlusion or kink. Now we'll carefully remove the tubing sets from the kit. Next, we'll remove the waste bag or the plasma bag. So this bag is where all the discarded plasma gets collected in the system. It's around 6 liter in capacity. Once removed, we'll carefully hang it on the hanger of the machine. After removing the waste bag, we'll secure it tightly on the hanger. Next, we'll remove the airbag. So this airbag is where the extra air gets collected from the system. Any kind of a air leakage in the extracorporeal circuit will get collected in this airbag. After placing the bag on the hanger, we'll now remove the tubing sets. So this is the draw line. As we can see, it has a red color roller clamp and it has another red clamp. The tubing set comprises of three tubes: a green colored double saline tube, an orange colored anticoagulant tube, and a transparent tube through which the blood from the patient's body enters the machine. So in this tubing set, the blood will enter and it will mix with the anticoagulant here, which will prevent any kind of clumping in the extracorporeal circuit. Now we'll place this tubing set on the hanger. Next, we'll remove the return line. Now this return line also has a blue colored clamp, as we can see, a blue roller clamp and a blue manual clamp. And it also has two tubing sets, a transparent tubing set through which the blood and the replacement fluid enters the body of the patient, and a green colored tube for normal saline. Now we'll remove the ACD line and the saline line. So orange colored is the ACD line or the anticoagulant line. The green colored coded tubing set is for the normal saline. Also, we have two transparent tubing sets which have a white colored clamp, and these are the replacement lines. Next, we'll remove the cassette and place it on the sensory board. This cassette, once placed properly, will give a click sound. We try to move it sideways to ensure that it is properly locked. Now coming to the pumps of the machine, we have the return pump. Next, we have the ACD pump or the anticoagulant pump. This is the inlet pump or the draw pump. Next is the plasma pump. And lastly, we have the replacement pump. Also, we have a sensor, the optical sensor of the machine, where the blood gets collected. It's also called the reservoir. It has a high level sensor and a low level sensor. The high level sensor will give an alarm if the RBC crosses a particular level. The centrifuge belt has four lines: an RBC line, a plasma line, a draw line, and a collection line. Through the draw line, the blood enters into the centrifuge belt and the component gets separated. So after checking this, we'll carefully open the centrifuge door using a lock which is provided here. Gently push the button and open the door. And now we can see the standard filler over here. Now we'll check the standard filler. It has a semicircular arm or the centrifuge arm, which is made up of the alloy. Next, we have our the loading ports, and now we'll see the filler latch, which has the locking pin. So this is the filler latch through which the tubing port enters, and this is the locking pin. Once the tube is secured, the pin will pop out. Also, we'll now see the loading ports. There are three in number, where the tubing sets will rest. And lastly, we have a leak detector, which gives an alarm in case the centrifuge belt breaks or there's any kind of leakage inside the centrifuge door. We'll now load the centrifuge belt inside the centrifuge. So first we'll open the the filler latch and pass the centrifuge belt through it. Once done, we'll now place this tubing set inside the filler latch. While placing, we should be very careful with the ports of the other tubings also. They should be placed appropriately on the loading port. The groove should rest on the provided support. Now, for the filler latch, once we have placed the tubing set, we'll place it inside the filler latch and ensure that the red color tubing part is closer to the groove present on the filler latch. Once it's placed securely, pull it down, and when we have pulled it, the locking pin will pop out, implying that the tubing is locked properly. Now we'll place the other tubing sets on the loading port. And now we'll unwind the centrifuge belt and gently place it inside the provided groove. While placing the belt, we have to be very careful that no part of the belt comes out and it is totally placed inside, because if any part comes out, it may break or may get cut during centrifugation, since the centrifuge moves at a very high speed. So as we can see, we are gently pressing the belt inside the groove, and we'll check it thoroughly at all the parts to ensure that each and every part of the belt is carefully placed inside the centrifuge. So after placing the belt carefully in the centrifuge groove, we'll turn the filler and check it everywhere once again. Once done, we'll check for the other ports of the tubing sets also. The last port is placed close to the centrifuge door and gently pulled upwards. Now we'll again do a final check. We'll check all the tubing ports that they are placed carefully and move the centrifuge arm again to check for any obstruction during the rotation. This is a very important step, because if there's any kind of kink, it will give an alarm and the procedure will get obstructed. So again, we have to ensure there's free movement. After loading the centrifuge belt, we'll carefully close the centrifuge door. Again, ensure that the tube is not getting obstructed in the door. Once closed, we'll press continue. Now, as shown on the screen, the cassette is getting lowered onto the sensory board. Once it is lowered carefully, we have to ensure that no part of the tubing set gets obstructed. Otherwise, it will raise an alarm. So ensure all the tubing sets are away from the cassette. Now, once the cassette is loaded, we'll now close the roller clamp and the yellow clamp present on the waste bag line and press continue. Once done, now the system will prompt us to close the clamps present on the inlet line and the return line. So we'll now close the clamps manually. So now the system is testing the tubing sets. Each part of the system, every pump will move in synchronization and check for the appropriate function. We'll now start with the priming. For priming, we require ACD and normal saline. So this ACD is orange colored and normal saline is given the green color. So for the anticoagulant, we are using acid citrate dextrose anticoagulant solution. We'll carefully spike this bag. For ACD, the orange colored code is provided with to the tubing set. So now we'll gently spike this bag. Ensure the spike is not a through and through spike. Once spiked, we'll press the drip chamber, fill it till half, and hang the ACD bag on the hanger. Now we'll place the tubing set inside the sensory detector present on the machine. Next, we'll prime the normal saline. For priming, we'll use a green color tubing set and spike the normal saline bag, which is 0.9% concentration. After spiking, we'll press the drip chamber and hang the bag on the hanger. And press start prime button on the machine. Now, as we can see here, the ACD line will get primed, the return line gets primed, inlet and RBC lines are primed, and lastly, the centrifuge channel is primed. So as shown on the screen, we'll now open the roller clamp present on both the lines, that is the draw and the return line. Once open, we'll press continue and the priming will now start. The acid line is already primed. We also have to give intravenous calcium gluconate support through a peripheral line to manage any citrate related hypocalcemia side effects. So now we'll enter the patient data. So first we'll select the gender. This is a male patient. Next we'll enter the height of the patient's body weight, and the hematocrit from the CBC report. The CBC report should be recent in order to calculate the total blood volume accurately. After calculating the TBV, we can then calculate the plasma volume. Once all the parameters are entered, we'll press the button of confirm. So now we calculating the plasma volume by manual method. So we have the patient's parameter is a male patient with weight 72 kg and hematocrit is of around 44%. So first we'll calculate the total blood volume. So for a male patient, the blood volume is 70 ml per kg. So TBV is calculated as weight into 70 ml per kg, which in this case comes around 5 liter. Next, to calculate the plasma volume, we'll use a formula as 1 minus hematocrit into the total blood volume. So in this case, one plasma volume comes around 2800 ml and 1.5 will come around 4200 ml. A similar values can be seen on the screen also. So now we'll go ahead with the procedure. We'll now select the replacement fluid, which can be plasma, saline albumin, or custom prime. After taking saline albumin, we'll now put the percentage of replacement, which is usually 100%. But here, since it's a renal transplant case, we require a 80% replacement. Once done, we'll press confirm. After this, we can now see that all the parameters have come. Since we are doing a 1.5 plasma volume exchange, we'll enter the value and the corresponding values will be displayed on the screen as shown. Once done, we'll press confirm button. So after entering the plasma volume, which is 1.5, which is to be exchanged, we'll see the corresponding parameters. So the volume of plasma which is to be removed and the target volume which is to be replaced comes up on the screen. Next, we can see the ACD infusion rate. That is the amount of ACD entering the patient's body per minute. This can go up to 0.8, 1.2, 1.4 like that. Next, we have the inlet ACD ratio, which tells that how much of ACD is being added to how much volume of the blood. So a ratio of 10 would indicate for every 10 drops of blood, 1 drop of ACD is being added. Also, we can see the total run duration of the procedure and the inlet speed. The inlet speed here is maximum is 120 ml per minute, but for plasma exchange, we usually start around 70 to 80 ml per minute. And in cases of pediatric patients, this can be as low as 30 ml per minute. And also, based on the choice of replacement fluid, the inlet flow rate may vary. So now we'll continue with the priming part. So as shown on the screen, we'll now open the clamps present on the draw line and the return line to manually prime the tubing sets. Once primed, we'll close the clamp and also close the roller clamp present on both the tubing sets. After closing, we'll hang the lines on the hanger. So after pressing continue, we'll now go on to the next step, which is to add the replacement fluid. So we'll now add the replacement fluid. So as shown on the screen, we'll take the replacement tubing sets and spike the normal saline bag. Now first we'll clamp the second replacement line and spike the saline bag. So here, as we can see, we have the two replacement lines. So we'll clamp one of them and using the other tubing sets, we'll now spike the saline container. So now we'll carefully spike this bag. Once spiked, we'll hang it on the hanger after pressing the drip chamber and priming this line. After doing so, we'll now unclamp the second replacement line as shown on the screen and allow it to be primed. As we can see, normal saline is entering the second replacement tubing sets. Once done, we'll close it and we'll place the tubing set in the sensory detector. After placing it there, ensure it's securely placed and press continue. Now as shown on the screen, we'll connect the tubing sets of the machine with that of the patient and open the clamps present on both the lines and press the button of start run. So here the axis is AV fistula. So we'll first check for the draw in the line. Once it is done, we'll now flush it. After checking the draw, we'll flush with normal saline. We'll repeat the same thing on the other line as well. So after flushing, we have connected and now we can see the blood is being drawn from the patient's body into the machine. So now the blood is drawn from the patient's body, enters the extracorporeal circuit as shown here, and from the cassette it goes into the centrifuge belt where it will get separated and the plasma will get collected. So as we can see, the procedure has now begun and these are the parameters. So the estimated duration of the procedure is around 157 minutes. At present, the flow rate for ACD is 5.5 ml per minute, the inlet rate is 55 ml per minute, plasma rate is 30.8 ml per minute, and the flow rate for replacement is 22.6 ml per minute. And so around 30 ml of ACD has entered the patient. The inlet has processed around 129 ml of the blood. 40 ml of plasma has been extracted, and around 19 ml of the replacement fluid has been replaced to the patient. And at present, the ACD infusion rate is 0.4 ml, zero point 0.4, and inlet ACD ratio is around 10. And also we can see here the pressure column. So the inlet pressure is minus 37 millimeter per mercury and return is 51 mmHg. So a green color will indicate that the pressure is adequate. In case it becomes yellow or red, it indicates any kind of an obstruction or rise in pressure, which may be attributable to different causes such as any obstruction in the line or in tube occlusion, and which must be sought after accordingly, and the needful should be done. So we'll now prepare a replacement fluid suspension of albumin in normal saline. We are using 1000 ml of 0.9% normal saline and 200 ml human albumin. The albumin is of 20% concentration. We will be diluting and making a 4% suspension. So for the purpose of diluting, we are using this 50 cc short tip syringe. So this is a loading syringe, and we have the needle of 16 gauge. So we'll now discard 200 ml of normal saline from the 1000 ml bottle. So carefully spike this normal saline container and remove normal saline 200 ml from this. So now we are discarding the normal saline. So 200 ml has now been discarded. Now we'll take the albumin and add this to the normal saline bottle. So for loading albumin, we are taking the 50 cc short tip syringe. We'll draw some negative pressure. This allows us to load the albumin easily. Now we'll spike the albumin bottle and load albumin in the syringe. Once loaded fully, we'll then add this to the normal saline bottle. Now, as we can see, we are adding normal albumin in the normal saline container. And the final liquid is frothy and slightly yellowish in color. This is the 4% albumin saline suspension. Mix it thoroughly. So now we can see this normal saline which was added initially is about to get over. So now we'll spike our saline albumin suspension container. So carefully spike the container and hang it on the hanger of the machine. Once done, we'll now unclamp the previous replacement line and open the line spiked in the saline albumin suspension container. And now we can see this solution is passing through the circuit. So now we are going to add FFP. So before adding, we'll check the FFP for the blood group and all the unit number, etc. We should be checking this from the compatibility report, which bears the unit number and the group of the patient. In this case, since it is incompatible, so we are using a AB group FFP. We check for the expiry date also. Next, now we can see here the replacement fluid that was saline albumin suspension is now getting over. So next we are adding FFP. Now FFP is added to make up for the loss of the coagulation factors. So in general, around 2 units of fresh frozen plasma are sufficient to replenish the loss. So now we are spike the FFP container, and once done, we'll now hang it on the hanger. After doing so, we'll unclamp the FFP replacement line. Now after doing so, we'll change the mode also. Sometimes you may get an alarm because if the replacement fluid is not started in the same go, it may give an alarm. Next, the choice of replacement fluid has been changed to plasma mode. And now we can see here the inlet speed has also reduced. So this can vary, as discussed earlier, it can vary depending on the replacement fluid. So now, as we had seen that we encountered an alarm while we were connecting the FFP bag. So this alarm was indicating that the replacement fluid was not detected. Now, in sometimes such an alarm can come at the time of changing the replacement fluid, because if the fluid is not connected timely, or if we forgot to unclamp the lines, this alarm can come. And as shown here, it may indicate the following reason for the alarm, such as the replacement fluid container was either empty, or the line was obstructed, or it was not correctly placed, or there was some debris. So we have to check for the corresponding cause, like which in this case was that the container was not connected. The existing container was empty and the FFP bag was not yet connected. So once we have done the needful, we'll press continue and proceed further. So now, as we can see here, we are towards the end of the procedure. 5 minutes are left. The last FFP is going on. And also we can here see in the plasma or the remove bag, all the discarded plasma has been collected. And now, once again, we are seeing all the targets are being achieved and the procedure is about to be concluded. So now, as we can now see, the procedure is completed. The run targets have been attained. So the targeted exchange volume was 1.5. The runtime is 143 minutes. The plasma which is removed is around 4029 was targeted, and we have removed around 4010 ml. So it's approximately nearly the same. And similarly, the replacement fluid is replaced was around 2770 ml. Now, once done, we'll press on rinse back so that all the blood from the extracorporeal circuit will now be returned to the patient. We'll now press the option of rinse back so that blood from the circuit is returned to the patient. Press rinse back. Again, press proceed to rinse back and confirm. Next, we'll close the inlet light and press continue. So now we have clamped the lines and the rinse back is now in progress. We'll open the inlet saline line so that saline can pass through the circuit and press continue. So as we can see here, INSPAC is now in progress. The saline is flushing out all the blood present in the extracorporeal circuit when it is going back to the patient by means of the return line. So we can see return line has a green colored saline tubing set and a transparent line from where the blood is being returned. And on the screen, we can see the return pressure, the total time for INSPAC and the INSPAC volume. Now, as shown here, we close the inlet and saline line, clamp the return and inlet lines, disconnect them, and seal the bag. So now we'll clamp the inlet roller clamp. Next, we'll close the return clamp. And now we'll start sealing the bag. So using the sealer attached to the machine, we'll seal the replacement line. Next, we'll seal the base bag. So while sealing, we should be careful to avoid any kind of spillage or leakage. We must press the sealer firmly and keep pressing it till the orange light goes off. Now we are sealing the airbag. Then this is followed by sealing the tubing set for ACD. And lastly, we'll seal the green colored normal saline tubing. So we'll now flush the AV fistula line. Since it's a AV fistula, we'll not be using Heplock or heparin. We'll flush them using normal saline, because with heparin, there is a associated risk of bleeding. So carefully flush the line. After flushing, clamp them and cover them with the respective cap. So similarly, we can see we are flushing the other line also. Usually 10 ml of normal saline is sufficient for flushing. Once done, clamp the lines and secure them properly with the cap. So now we'll press unload, and we can see here the ACD which was used, the remove bag volume, replacement used, the bolus, start time, end time, etc. the parameters. Next, we can see the plasma volume which was exchanged, the total plasma removed, ACD removed. And now we'll press on new procedure for another procedure. And here, as we can see, the cassette is getting unloaded. It is getting raised from the sensory board. The reservoir is also emptied because all the blood has been returned to the patient. So now we'll carefully remove the cassette by pressing on the latch. The cassette can be now removed, and then we'll remove all the tubing sets. So now we are removing the tubing sets. So the tube which was inserted the last is being removed first. We are removing the first tubing set from the centrifuge door, after which now we'll remove it from the loading ports carefully. We have removed it. Now we'll remove the tubing set from the inside of the centrifuge chamber. So here we can see the locking pin and the filler latch. So we'll gently press on the filler latch and lift it, and we'll press the loading pin inside, and the tubing will be now pushed forward so that it can be removed. Once it is removed, we'll now remove the centrifuge belt from the centrifuge chamber. Once it has been removed carefully, now we'll take it out entirely from the chamber and close the centrifuge door gently. And lastly, we'll discard the kit in the appropriate waste bag. So now, after the procedure has concluded, it is equally important to discard the kit appropriately. So in this case, the used kit, which has the saline and blood, along with the plasma waste bag and the empty bags of the FFP, it is all discarded in the designated yellow waste bag.
So thank you, Ankita, for taking us through the complete installation, the procedure of therapeutic plasma exchange, the ending of the procedure, and all the documentation part. So now I have a few questions which are quite oftenly asked, or there are queries which the students face. So my first question to you is, like, you spoke about the filler which is used here in the Optia system. So there are two kinds of filler. One is the ideal filler and the other one is the standard filler. So can you explain us what is the difference between the two fillers and where each filler is used? What is the purpose of each filler? Thank you.
Thank you for your question, Dr. Soma. So, as we can see here, on the left is the ideal filler image, and on the right, we have the standard filler image. Now, the standard filler has a leukocyte reduction chamber slot. So, the purpose of this LRS chamber is to reduce the leukocytes. Now, this function is not of any use when it comes to plasma exchange. However, since we are using the same filler for the purpose of performing plasma exchange and as well as platelet collection, so the platelets are leukoreduced products. Therefore, we have the LRS chamber in the standard filler. And in cases of ideal filler, we do not require a LRS chamber because the collection is based on the Buffy code, and we perform stem cell harvesting and granulocyte collections using the ideal filler.
So yeah, thank you. So the routine or the standard filler is used for the therapeutic plasma exchanges, and the ideal filler is usually used for the hematopoietic stem cell harvest, the granulocyte harvests. So coming on to my next question, as to regards to this kit which is used for therapeutic plasma exchange. So what is the extracorporeal volume of this kit?
So now coming to the next question, the extracorporeal volume in cases of the therapeutic plasma exchange procedure. So this volume in the circuit is somewhere around 140 ml to up to 185 ml. And this volume indicates the volume of the patient's blood, which will be present in the circuit all throughout the procedure.
So it's been known that the Spectroptia is equipped with an AIM system, or commonly called as an AIM system, which manages the interface. So could you please briefly describe about this AIM system and how does it help in collections?
So the AIM system, or the automated interface management system, performs three functions. Firstly, it adjusts the pump to manage the position of the interface and efficiently removes the targeted component. Second, it monitors the interface position and the thickness of the separated blood component using a unique optical device. And lastly, it interprets the interface information and allows the collection of the desired component accordingly.
So right, so in this case which you showed, you use the AV fistula as the venous axis for this patient. So can you elaborate on the other venous axis which can be used for performing therapeutic plasma exchange?
So there are different types of venous access for performing the therapeutic plasma exchange procedure. In this case, we have used the AV fistula, that is the arteriovenous fistula axis. The other axes include a central line axis, which can be an internal jugular vein or a femoral vein, or we can also use a permacath for performing plasma exchange procedures.
So during the start of the procedure, you also spoke about the custom priming of the circuit. So could you explain what does custom priming mean and what are the different fluids which can be used for priming the circuit?
So the custom priming can be done using packed red cells, saline, albumin, or fresh frozen plasma. The purpose is to maintain the volume in the extracorporeal circuit. The ECV volume in the circuit, it should not exceed more than the 15% of the TBV in cases of an adult patient, or more than 10% of the total blood volume in pediatric patients. So the preferred uh, fluid for custom priming is usually packed red cells. We use a ABO-RH matched AHG phase cross matched compatible packed red cells are used, and the purpose is to maintain the volume in the extracorporeal circuit so that the incidences of any hypotensive reactions can be minimized. And in certain cases, after performing the procedure, if the hemoglobin of the patient is low, or if in certain cases where there is a associated hemoglobinopathy such as thalassemia, we also do a rinse back. That is, the volume of the extracorporeal circuit, whatever blood was present in the circuit, is returned to the patient. And this rinse back may be done completely or partially as per the requirement.
So thank you. So we saw that there are various custom prime fluids